Let's move on to our next presenter here today, somebody from within the Care Oregon family. We are the pharmacy department at Care Oregon, presenting you MedZed. And so we have a couple of our pharmacists who are coming on board next to help us through some of the next pieces of content that we're going to be covering. I'd like to have you meet Oyinda Osibanjo. She is Senior Pharmacy Clinical Coordinator here for Care Oregon. She got her pharmacy degree in Nigeria and then went on to receive a master's in public health from the University of Leeds in the UK, and then her PhD in public health from Oregon State right here. She most recently was a clinical pharmacist for Yakima Valley Farm Workers Clinic, providing clinical pharmacy services to patients with diabetes and on anticoagulation, and has worked in community pharmacy as well. Oyinda is very passionate about improved healthcare for our low-income and underserved population. It's great to have you with us this morning, Oyinda. Please take it away.
Thank you, Paul, for that kind introduction. I'm actually excited to be here with you all today. And today we'll be focusing on naloxone co-prescribing. Now, naloxone co-prescribing is one of the key strategies to addressing the opioid epidemic we're currently facing in the US. And I would like you to view naloxone co-prescribing in the same way you would view prescribing a stool softener for a patient who is on opioids, and you are addressing that common side effect of constipation associated with taking opioids. In this case, we're addressing opioid-related overdose. And by increasing naloxone co-prescribing, we're able to expand the access of naloxone to a high-risk population who are at risk of opioid-related overdose. Now, the goal of today's presentation is to actually advocate for naloxone co-prescribing at your various practices. Now, at the end of today's presentation, you'll be able to identify patients who are candidates for naloxone co-prescribing based on their risk factors for opioid overdose. And also, you'll be able to understand the role of pharmacists and other healthcare providers in expanding naloxone co-prescribing. And at the end, also, we'll be able to address your concerns or questions or any issues related to naloxone co-prescribing. Now, based on the data that has been shared earlier in this presentation, I know we are all aware that opioid overdose and opioid overdose related deaths is a huge public health concern in Oregon. But we know based on evidence that naloxone can help reverse that life-threatening respiratory depression associated with opioid overdose. Now, by ensuring that we provide naloxone to our patients, then we can help potentially save lives. We are also aware that a lot of our providers are open to naloxone co-prescribing, but they face several challenges. And one of these key challenges is identifying patients who are candidates for naloxone co-prescribing. Now, the CDC and the HHS has actually provided guidelines to help identify these patients. Now, patients who are receiving opioids of a dosage of 50 morphine milliequivalents or more daily will be considered candidates for naloxone co-prescribing. Also, patients with a history of overdose, patients with a history of substance use disorder would all be considered candidates for naloxone co-prescribing. I'd like to emphasize at this point that regardless of the opioid dose a patient is taking, if a patient falls into any of these categories, you would want to consider this patient a candidate for naloxone co-prescribing. So a patient who has a condition of COPD or obstructive sleep apnea, patients who have been prescribed benzodiazepines, patients who have non-opioid substance use disorder, patients with reported cases of alcohol use, and patients with mental health disorder. Now, another category I would like you to consider naloxone co-prescribing for will be patients using heroin, illicit synthetic opioids, or misusing prescription opioids. Also, patients using other illicit drugs such as stimulants, including methamphetamine and cocaine, which could potentially be contaminated with illicit synthetic opioids such as fentanyl and the fentanyl analogs. Also, patients receiving treatment for opioid use disorder, including medications such as methadone, buprenorphine, or naltrexone. And lastly, patients with a history of opioid misuse that were recently released from incarceration or other controlled settings where tolerance to opioids has been lost. Now, I would like to make this practical in terms of understanding the commonly prescribed opioids and the morphine equivalent dose. So, for example, if you're prescribing 5 milligram Norco or even dispensing 5 milligram Norco to a patient, and Norco is a combination of hydrocodone and acetaminophen, which is used to address pain. And the SIG for this 5 milligram Norco states, take 2 tablets every 4 hours for severe pain. This would be a candidate for naloxone co-prescribing based on the CDC and the HHS guidelines. Also, a patient who is on oxycodone, 15 milligram, the sustained release formulation, and taking approximately 2 tablets daily would also be a candidate for naloxone co-prescribing. See, I've also added here for you the opioid med calculator to help you understand the commonly prescribed opioids and their morphine equivalent dose. So the idea here is to provide you with those practical day-to-day opportunities to provide access of naloxone to this high-risk population who are at risk of opioid-related overdose. Now, in my next slide, I will be highlighting the risk of concurrent use of opioids and medications such as gabapentinoids, benzodiazepines, and antipsychotics. Now, as of 2019, the FDA put out a warning on gabapentinoids and opioids. Now, gabapentinoids are basically gabapentin and pregabalin, and they're used for seizures, neck pain, and restless leg syndrome. Now, the FDA put out a warning as of 2019 of serious breathing difficulties when gabapentinoids and opioids are used concurrently. And as a result of this, as of January 1st, 2020, gabapentin was included as a covered substance for the Oregon Prescription Drug Monitoring Program. Another major concern is the use of opioids and benzodiazepines. And this is a major concern because concurrent use of opioids and benzodiazepines is actually associated with the risk of respiratory depression and even death. In fact, a study has shown that when benzodiazepines and opioid prescriptions are used concurrently, this may actually quadruple the risk of overdose deaths compared to just using opioid prescriptions alone. Now, another concern we have is actually that concurrent use of opioids and antipsychotics. You see, second to benzodiazepines, antipsychotics were most frequently found medications post-mortem of opioid use disorder. And a lot of patients have actually reported using antipsychotic medications to enhance the effects of their opioids. And this can lead to, or even cause, respiratory insufficiency. As a result of this, one of our requirements for our Support Act opioid review is to actually track patients on opioids and benzodiazepines and patients on opioids and antipsychotics and implement interventions. We're also tracking patients on opioids of 50 morphine equivalent dose or more who do not have access to naloxone. Now, this slide actually provides a comparison of patients who are on opioids of 50 morphine equivalent dose or more with access to naloxone and patients on the same dosage regimen range of 50 morphine equivalent dose or more without access to naloxone. And you can see that huge gap. And this is a call to action for our healthcare professionals. And what are we asking you to do? We're asking you, our healthcare professionals, to actually discuss the availability of naloxone with your patients when you are starting or even renewing treatment for your patients. We're also asking you to consider prescribing naloxone based on the patient's risk factors for overdose. And we also like to recommend that pharmacists offer naloxone to their patients when, this filling a prescription for opioids of 50 morphine equivalent dose or more daily. Now, to help address that barrier of access to naloxone at the pharmacy level, the Oregon Board of Pharmacy has actually expanded its laws to allow pharmacists to prescribe naloxone and the necessary medical supplies to administer naloxone to patients who are on opioids of 50 morphine equivalent dose or more, to an individual seeking naloxone, and to an entity seeking naloxone. The idea here is to expand naloxone access and potentially save lives. Now, the question you're asking is, how do you implement this in your everyday workflow strategies at your various clinics and even pharmacies? And we have some strategies for you. So what are those possible workflow strategies you could implement? So for example, clinics who are treating opioid use disorder could actually prescribe naloxone to all patients on their initial visits. You could also consider developing work groups that include family and friends on how to use naloxone and even respond to an overdose situation. Also, at the primary care clinic level, medical assistants could review the records of their patients to ensure that patients who are on opioids of 50 morphine equivalent dose or more have access to naloxone. And if they do not, initiate that conversation and prescribe naloxone for these patients. Now, at the pharmacy level, this is the opportunity to train technicians to identify patients who you would consider candidates for naloxone co-prescribing. And we believe this will help improve the uptake of naloxone at the pharmacy level and help to initiate that conversation. Now, I'll be talking about barriers and concerns associated with naloxone co-prescribing, and there are several barriers. But one thing I've done is to stratify these barriers into the patient level barriers and the provider level barriers. So first, we'll be discussing the patient level barriers. And one barrier the patients have highlighted consistently in studies is social stigma. Several patients report being labeled as addicts when they either request for naloxone from even their providers or even fill naloxone prescriptions at the pharmacy. Now, this is where we, as healthcare providers, ensure that we use patient-centered language that is non-judgmental to communicate with our patients. You see, by using a patient-centered language, we're able to ensure that we create a safe environment for our patients to either request for naloxone or even fill naloxone at the pharmacy. And we're not only engaging them, but also being able to expand naloxone access to this high-risk population who are at risk of opioid-related overdose. You see, what we want to do is that we want to potentially save lives. And by ensuring that we communicate with our patient, we can help them, engage them, and provide naloxone access to them. Now, another barrier is the cost and coverage of naloxone. And for our Medicaid population, the cost of naloxone is covered with no copay. Now, for the Medicare population, it's based on their government subsidy. So for some patients, based on the government subsidy, their copay could range from $1 to $3 for the generic product of naloxone, or sometimes $4 to $9 for the brand product of the naloxone, which is the Narcan nasal spray. Now, for uninsured patients, we do have the harm reduction programs or the syringe services programs that provide naloxone to patients at no cost. And we do have these resources available to share with you. So you can refer your patients, particularly the uninsured patients, to be able to provide and expand the access of naloxone to this high-risk population. Now, there are two key formulations for naloxone, and we have the injectable formulation and the Narcan nasal spray. Now, the injectable formulation comes as a 0.4 milligram in 1 ml, and the benefit allows 2 vials per each prescription fill. Now, when you're writing a prescription, you want to include for intramuscular injection in an event of an overdose, and a patient will need syringe and needle when you're writing a prescription for naloxone. An injectable for the injectable naloxone prescription. Now, for the Narcan nasal spray, it comes as a 0.4 milligram in 0.1 ml Narcan nasal spray. And the benefit allows 1 package. That means it contains 2 spray devices per each prescription fill. Now, when you're writing a prescription, you want to include for nasal administration in an event of an overdose. And in this case, no auxiliary items are required. Now, lastly, at the provider level, One key barrier that has been highlighted at the provider level is logistical barriers, and that is training and education for our pharmacists and even our physicians in terms of improving that comfort level to be able to effectively communicate and discuss naloxone co-prescribing. And that's why we put this med heads together for you to ensure that we empower you, our providers, to be able to effectively communicate and discuss naloxone co-prescribing and expand the access of naloxone to our patients. Now, we've put together some practical ways you could actually initiate the conversation of naloxone co-prescribing, and you could actually compare naloxone to a fire extinguisher. So naloxone is a lifesaver, like having a fire extinguisher. Hopefully you won't need it, but it is important to have it on hand just in case you do, for yourself or for someone else. You could also compare naloxone to a seatbelt. You probably won't need it, but if you do, it can save your life. And I like this one, comparing naloxone to an Epipen. Naloxone is for opioid medication, like an Epipen is for someone with an allergic reaction. And this helps to destigmatize the conversation and the idea of having naloxone access, because everyone who has allergic reaction will potentially carry an Epipen in their bags, and they would have it for a long time without having to use it. And that's the idea we want to help people understand, that having naloxone does not stigmatize you and helps to initiate that conversation and makes you comfortable enough to be able to communicate and discuss naloxone with your patients. We also have more resources at the end of this presentation whereby you can review, and that would help you and guide you in initiating conversations with your patients. Now, one key concern that has actually been highlighted consistently is that the perception that increasing naloxone access actually results in increased opioid use. And several studies have shown that this is not the case. In fact, studies have shown that in some cases, having naloxone access does not change the opioid use behavior of patients. And in other cases, it decreases the opioid use behavior. But one thing that has been consistent is that providing naloxone access has helped to decrease opioid overdose-related deaths. And also studies have shown that patients that have access to naloxone do not harm themselves or even individuals around them. I would like to emphasize at this point that naloxone is a tool, a harm reduction tool, and not the treatment for opioid use disorder. You see, the goal of having access to naloxone is to help provide a life-changing intervention, to help these patients seek opportunity for long care treatment. You see, we're giving them a second chance to make the right choice. I hope this has helped to address that concern that providing naloxone leads to increased opioid use. You see, you, our providers, have the potential to save lives by increasing naloxone co-prescribing, so use it. If you do have any questions, I would like you to put it in the chat box and we'll be happy to address it. Thank you all so much.